one speaker that I'll introduce soon, and then we have a panel of 4 speakers. So I'm going to request the main speaker and the panel to come up as I introduce them. So we'll have a presentation by Professor Freddie Sengoba. Professor Freddie is a professor of health economics and health systems management with over 20 years of teaching and research in health policy and systems at the Makerere University School of Public Health. He is also a director of the SPEED project and also the Center for Health Policy and Systems Development. He has a background he has a medical background, he's a clinician, and actually also served as a DHO in his earlier years. He has a doctorate from the University of London. He has accomplished a lot, and I won't tire reading that. Most recently, he's engaged in a number of multidisciplinary teams. He's embedded in a lot of what's going on at the national and regional level in regards to health systems strengthening, and he really contributes a lot within the think tanks and academia, as well as advisory boards for the National Planning Authority, WHO, AFRO, Wellcome Trust, and Health Systems Global. So I think we have the right speaker to really make the first presentation. I will also request the panel to come up because we're out of time. I'm going to introduce next. The first panel speaker is Dr. Batiwe Emmanuel. Dr. Emmanuel is the Senior Executive Consultant of Mubende Regional Referral Hospital, which oversees service delivery across 5 districts, and he's been supporting integrated service delivery within that region. He has built a distinguished career in health systems management at different levels. He's also previously a clinician, and he successfully led a number of initiatives to improve quality of services within Mubende Regional Referral Hospital and the region in general. He currently chairs the Forum for the Regional Referral Hospital Executive Directors in Uganda. Dr. Batiwe, you're very welcome. Next, I'll introduce Dr. Cordelia Katurebe. Dr. Cordelia is a pediatrician and child health specialist, currently working as the coordinator for the MOH COAG. She carries a lot of experience, especially in clinical care, strategic planning, and implementation of public health programs. She currently coordinates the development and supports the implementation of Uganda's integrated service delivery. She's been a big force in operationalizing a lot of what we've had today in regards to integration. Dr. Cordelia Katurebe, you're very welcome. Next, I will introduce Dr. Rita Makabai. Dr. Rita is a capacity building advisor at the Baylor Foundation in Uganda. She's also a clinician by background and a public health specialist with over 19 years of experience. She has served in several places, including the Infectious Diseases Institute, the FIND Diagnostics Project, which is actually a global international project. She currently serves with Baylor Uganda and supporting the implementation of integrated service delivery, especially in the Fort Portal Mubende and Bunyoro regions. She's also based at the Center of Excellence in Mulago. Dr. Rita Makaba, you're very welcome. Last but not least, I would like to introduce Amy Potter. So Amy is the health advisor for the Foreign Commonwealth and Development Office, FCDO in Uganda, where she advises on the Global Fund Accelerator and global health initiatives. She's a senior leader and she's very experienced in health with diverse experience in a number of countries, including the UK, Gambia, Sierra Leone, Liberia, Ghana, Nigeria, Uganda, Bangladesh, Maldives, and most recently Malawi. She has experience in donor funding mechanisms and advises Ministry of Health in coordinating these initiatives and a number of other funding initiatives from development partners. So very interesting panel discussion ahead and presentation. But first, I'm going to request Professor Freddie to come and make the presentation. I hope that is up. Can we please have the presentation? Okay. Yes, that's here. Should be coming up soon. You're welcome.
Thank you, Dr. Aveni, and moderator for this afternoon. Ladies and gentlemen, good afternoon. I want to ride on the protocol for this meeting. I know there's been variously shared with you. Allow me, first of all, to thank the organizer for asking me to speak on this very important topic of integration. Along the way, when my slides, they are already up, allow me also to appreciate Clinton Health Initiative and the Ministry of Health for the work that they've asked me to lead over time thank you. So since January, actually before January, I think it was November, that I was told that this work will be out for bidding, and in January I got involved, and as soon as I got involved, there was additional asks as the orders started flowing in from across the Atlantic. So the task became much wider, but as just to confirm, as the chair has just said, that this agenda was on the Ministry of Health for a longer time. Initially, it was not necessarily focused on HIV per se. It was across the health system. And my presentation will actually try to be more comprehensive, but in areas needed also a focus on HIV. Allow me also to thank the FDDO, which is presented with us here by Amy, because they've been the main support and brings support to this work through CHAI. Thank you so much for the support we've received doing this work. I've had a committee that has also led this, what I'm going to present to you. The committee members are also thanked. We've conducted extensive data. I'm happy that Dr. Cordelia is here and Dr. Stavia, I think, is in the room. Much of what I'm going to share with you is what the task force they lead has also been generating, and therefore helping me to get the material to actually organize and deliver this. This work also would not have benefited a lot if there was no that famous guideline, or was it, was it called? Circular from the permanent secretary that went ahead, that kickstarted the agenda for integration. All of those I wish to appreciate. So, ladies and gentlemen, my title, is it? Okay. I think you've already seen it. Ideally, this is health service integration in Uganda, and particularly, I can see it from here, responding to financial instability and systems fragmentation. And this, as we shall see, these are the major shocks we are talking about. Some of them are acute, but as you also know, some have been here for some time, and there have been a deliberate effort over the years to try and achieve integration. Every time anyone who has been in Uganda for some time will note that our systems have been very wired around integration right from the time we adopted PHC as one of the framework for us to organize health services. But of course, those who are students of PHC will note that as early as PHC was constituted, there was a breakaway group to say, look, we can't deliver all of it. Can we deliver a few vertical programs? And so when I was being schooled early in my MPH, we had of those discussion of comprehensive versus a smaller package of PHC. We've had a swap here, which was a sector-wide approach, again trying to coordinate ourselves, try to reduce the early disintegration that that discussion brought about. We've had aid effectiveness agendas, which also came in to try and continue pulling us back. We've had reforms around donor pooling. Decentralization itself came to really coordinate care around the needs of the community at the lower level. And here we are, 2025, we are also talking about new policy shifts to strengthen integration, which means we've had a pendulum back and forth, and we hope that we can this time stay the course and achieve the objectives of this agenda. So overall, the goal that was set for this work by the ministry, and I must say, we've gone through the study and clearance levels. Dr. Cordelia here will tell you, you go through the initial working group, the committee, then you go technical working groups, then you go to senior management, then you go to HIPAC, then you go to top management. All of these are clearances. Partly is also filtering what should actually be sector position and how we take this forward. And I must inform you that we've been all the way to top management, and this has now been endorsed to be the position. The actual report and paperwork will follow, but my presentation is briefly to tell you what is coming. But I know also that many of you have been implementing this, especially at facility level. But the goal is simply to build a resilient, people-centered health system capable of delivering continuous integrated care across the life course. In there are issues of how do we institutionalize this so that we stop this back and forth, pressures of disintegration, fragmentation. The other issues, how do we deal with the fundamentals to ensure that disintegration does not create the risks or the fears. Every time we went to collect data, we were interfacing with clients, particularly clients of HIV and people living with HIV who were concerned about the quality decay or the introduction of fees and other fears, as you can imagine, when a major funder stops funding. And the whole issue of domestic health financing has been key. And we've had another major dialogue in this place, I think around April, again, to try and fine-tune the demands and the approaches to mobilizing more domestic funding. The other element there is about going or strengthening platforms of care. I know that much of the efforts that started were in the facilities, and most facility managers and the people there, or at least stakeholders at facility level, know what the integration is about. But we need to go beyond the service platforms in the facilities and look at all the other service platforms. I was happy to hear the last session was talking about how do we even try to take TB care outside of the facility and try to achieve better. In another down there also I was hearing how delivery platforms at community level are being leveraged, schools, workplaces, and many other platforms that we really need to bring. And as you know, this integration cannot only be a discussion in the health sector, because some of the drivers of what we are suffering from in terms of demand for care, cost of care, is coming outside of the health sector. So we need to engage with our people on the roads and road management and transport, how we can reduce things like, you all know, hospitals are full of people from road traffic accidents and borders. If you go to the surgical ward, the resources, much of them are really trapped into what happens in that industry. We cannot succeed without engaging and integrating our messages and development with them. But broadly, that is the agenda. The key problem we are trying to solve is the whole issue of fragmentation. I think we've been privileged as a country and a continent that we received a lot of funding to capitalize and to improve some services that we otherwise not have improved. I was here when HIV did not have medicines, and my family members, many of them, did not survive when the medicines came. Some of them had already gone. So we need to celebrate a lot of support we've received over the years to try and change a situation that was hopeless to now, which is we take for granted. But clearly, of course, as we have seen, we also need to be preparing for readiness to take on these responsibilities. I always want to say that actually there's been a lot of preparation for transitioning for aid financing, although when this was announced in January, many of us thought it was abrupt. But I want to tell you that in 2014, we started actually getting donor transition programming. Some of it was happening from to go to high volume facilities and leaving low volume facilities. Some was going in particular directions, but it's been around. How we've prepared, I think was, and I'm glad, I don't know that it was here in the morning, we did not get that feeling that it can go away. We must say it will come back some way, or it will not go away somehow. But I think what we have witnessed is the lack of taking seriously the transition agenda. The abrupt withdrawal, of course, one can say abrupt, but frankly, I have a student I started mentoring for PhD. He took 4 years to finish. He was studying donor transition. It's called Henry Zakumumpa. If you actually look at some of his papers, they're as old as 2014. So we cannot claim that we've not been in this space. But the point I think I want to draw on is that there will be this integration that we need to fix. We need some lack of readiness that we really needed to take responsibility for, and we need to pay attention to domestic financing. The shocks, of course, has implication, and this is what worries all of us, and we need to see how to mitigate this. The issue of how it has affected, for example, the NCD space, the HIV treatment and programs being disrupted. Of course, all of these are issues, and we know that we have a big population of people who we need to provide continuous care for, and these are important gains we don't want to lose. We also know we've been doing very well in our programs, particularly for HIV and TB, but these shocks do speak to the risks of disruption. And as I said, we really need to take these risks collectively as a government, collectively as experts, and of course, maybe a little bit for the funders who did not give us enough time to catch up. But the principles of integration that were used to prepare the roadmap and the framework that we're going to share are these: a people-centered and life course approach, so that whoever comes within care, or before even they come to care, we are actually paying attention to their needs. Some of their needs are going to be clinical, some of them are going to be social, some of them are going to be mental health, some are going to be in the policy development mode where they need to get cash. In other words, we really need to pay attention to and center those people we care as people, as communities, as families. We also need to ensure that primary care remains the foundation of what we do, so that we create that system of trying to deal with care at the primary level as well as referral. Co-production is important, and the agenda now requires us to actually invite communities into the space to lead where they can lead, and to be with us in designing what can be delivered. So this integration agenda has also taken us back to rethink how do we engage communities, and how can they be key partners in the road to a more integrated and sustainable model. Of course, wider determinants of health, and the three ones we've all heard about. So eventually out of this, and I'm going to start with literally like the end product of that work that I've been doing, which is the roadmap. We've eventually produced a roadmap. A roadmap is a way to guide what we need to do in this space as a country. And within that roadmap, we've actually invited all stakeholders and assigned them roles that we think are already in their mandate, so that we can collectively deliver this as a distributed product. But we thought that, and I've seen Ugandans, they want to do everything at once. Every time I've presented the roadmap and said it's 3 phases, say, why are you putting it in phases? Why can't we do it all together? But I've also seen the risk of trying to do everything at once is that if you go back to the story of Health Center 4 Chair, allow me to digress 1 minute. We started this health center back in the time of Dr. Chiyonga when he was Minister of Health. And the idea was for them to deliver and help us reduce the maternal mortality when the MDGs were about to come. The idea was have a doctor, let the doctor be able to do a cesarean section at the closest point at the facility level. Let's give them a theater, let's give them an anesthetist, and all that require, at least to deliver that, plus the baby, to ensure that what we call, what is that EMOC part, which is slightly less, that is delivered at health center. It took us almost 12 years to get these elements all together in a few health centers, FORs. Every time we took the doctors very quickly. After 4 years, we started building the theater. After another 4 years, we started training the anesthetist. Another time, then we started looking for equipping. By the time everything came, the doctors were so scared. They've not done cesarean section for almost 10 years. They all came to public health to do masters in public health because they could not manage the cesarean section. In other words, the reform is being implemented in small pieces. Every piece is taken everywhere, every small piece taken everywhere. At the end of the day, when things were about to add up, we had still not turned the maternal mortality indicators. And I think this is a challenge. Let's not do everything everywhere all the time. Let's first do. That's why we're saying we have a phase which is very urgent. Can we first focus on that? Yes, if you are in a phase, if you think you can do phase 2, a few items, fine, but we don't want you to be lifting the entire load at the same time. So stabilization is what we thought is about importance. And I think those of you who were here in the morning, Professor Sewedo also talked about this issue. How do we stabilize the system, especially when we are in the middle of the storm? And that we think is about issues around essential services and their continuity, ensuring that we have medicines, we have diagnostics, we have health workers. Those are part, and the data systems. Those are the major ones that you want to start with because they are critical to going forward. And once you think those are stable, then we can consolidate those and start to build around them, ensuring that now we take integration to all other aspects, as I was talk briefly. Align the financing, of course, strengthen primary health care because we know it's still young. There are areas we need to strengthen, to expand. And of course, the rest of the journey will be to transform this into a modern, like we go to Europe or we read about systems in America. But that is the roadmap. The point is, we don't have to bite everything at once. Let's take those that are urgent as priority and later pick up the consolidation and transformation. So out of this work, we are lessons we've learned, and I'm going to talk about some of these, although I'm not going to cover all of them. We have about 10 lessons, and on the slide, I could only fit 6, and the time I could only fit 4. So many framework. Whenever I talk of integration, everybody has their favorite in mind, because we've been integrating something. Within HIV, we've integrated many things. Cancer care, we integrated TB, we integrated other screening, maternal health, and everything. So there is integration within integration. But what we are talking about here is about trying to integrate across the health system so that we allow these platforms to be able to deliver more than just the specialization of a particular service. And the other issues about service level focus, I know that the aspect that have gone forward since the circular has been facility level, but also we see that many of the discussion at that with those groups are asking for, can you provide more drugs? We need some space. The diagnostic equipment, I need the repair, I need the service, need supplies. In other words, we are asking the upstream also to play some role. It's not enough to ask the front line to integrate because they are going to need support from upstream. The other issues about costs, we think that, yes, we can achieve efficiency by integration, and that's one of the goals. But we also know when you integrate in a younger system, you need also to expand it. There are going to be costs to grow the system so that it becomes more strong. So there are costs, as we talk of cost saving through integration, we are also expecting investments. And of course, governance is important. And for me, I'm very happy for this session, seeing, first of all, the academia and the ministry integrating into one conference. Already, I think we are walking the governance space. And Dr. Stavia, thank you so much for leading us. Let's give her a big round of applause. So these things is happening even at this level. Now, let's see how we can take it all the way down so that we all work in a ways that can save resources where we can save them. As a judge, we always spend a lot of money, and they also, Ministry of Health, make a lot of money to organize this, but now I believe there are a lot of savings. For government, I think we need to appreciate that they are beginning to actually expand the funding that they are giving for health. And I think the last budget we got more. And if the information I got is reliable, there may be a supplement coming. We can clap for it even if it's not here yet. Just to reinforce that you don't need a supplement. There's no clapping. Let's clap for our finance and government, but at least this is consideration, because clearly we are going to need more of what we are sharing from there and look at alternatives. But also we can't do it all. Communities, me and you, where we stay. Because sometimes when we talk of communities, people kind of think we are talking of other people there. Let's try to mobilize and expand, whether knowledge, whether leadership, whether self-care, whether advocacy, so that we can empower the communities to be able to live a life that does not require them to come into healthcare and spend resources that we don't have. So, one of those lessons was about framework, and I think the title in your book is about integration framework. Now, when we talk of a framework, some of us professors are accused of being too academic. So there are so many frameworks out there. So I figured that some of you may go away wondering, what framework is Professor Fred talking about? So the picture here is simply to say, if you have an idea of making a horse, and the horse standing on two legs, there is something that we call, what is that, scaffolding? Have you seen what we call scaffolding? You put some metals or wood or structures that look like a horse standing on two legs, and then you can bring mortar and put, then eventually when you leave, the mortar and everything you've done will be able to hold the shape. Does that make sense? So for integrating, we also wanted to look for something to hold the shape. And we went to that table, I don't know if you can read it, but there are about 8 different elements. Elements that are important for us to hold the shape of the integration we need to put in place. And much of it comes from the health systems building block many of you are familiar with. But here I wanted to explore the area of the person, the family, the community. That is the first one we put as core. So that whatever we do is person-centered, family-centered, and we try to organize everything we do with that. The rest of the components are similar, but also we brought in community so that community is given enough importance in this agenda of integration. Meaning that when we talk of integration, we would not only want to see integration at the service delivery, which is number 2. We want to see how is the leadership also managing integration. Many reasons that I was given during this study show that much of the integration starts with the Ministry of Health and the donors they work with. They come and say, oh, you know, Uganda is behind on this issue. Can we do something? Then they go for a grant. They get it for 3-4 years. Before you know it is 10 years, they are still, and then the program is now specialists. Before you know it, they are even parallel systems that deliver it, and is even taken out of the system to be standalone. I'm sorry if I'm putting too much blame on that, but the point here is we need leadership to pay attention that when you start something, you need to bring it back into the fold so that it does not run along its own life and separately. We need to pay attention to the workforce, financing, I've already talked about this. And the other aspect we've done is using those elements. We've also gone around to see how the programs we have are faring around those elements. And you can see some programs are faring more in governance. Sometimes the issues to do with finance and supply chain and some elements of workforce are less integrated. And that speaks to some areas where we need to pay more attention to. We've also tried to ensure that for each of those elements you've seen the table, we actually have them looked at facility level, at the region and district level, and at national level, meaning that the duty bearers at facility level are going to do their part. They are going to need support from the district and region. They should also do their part. And those, if both those two do their part, most likely the ministry is going also to be required to come and support those, so that we have actions at all levels that are aligned to integration. And here is an example of trying to look through the workforce. So at facility level, people can pay attention to the skills and staff training they have and recruitment, and issues to do with staff buy-in and trying to look at role structuring. But you need district level also to bring in some issues. How do you deal with winners and losers? How do we recruit those people and put them on government payroll if they are on a contract payroll? At national level, how do you provide guidance and cooperation around how this is done? And also, in the interim, how do you repurpose some of the money around to support absorption? We've done that across all the other elements. And the guidance is both in a situation analysis, which is going to be reaching, I believe, you soon, and the integration matrix that we have developed to allow you to assess where you are and how to move from where you are to the next level. And I'll talk about that briefly. The other lesson we've learned is about costs. As I talked about the issue of people think integration is cost saving and may not think that more money is required, but actually may require more money in particular areas quickly. I was speaking to a friend who was telling me some machines that require a lot of expensive cartridges. And if you don't have that, your TB screening and may actually stop immediately. So you want to ensure that you have that. If you integrate other cases and they also need screening, you are going to need more than you used to have in the HIV clinic. If you are going to integrate other groups and you're going to measure their blood pressure and check whether they have high blood pressure or diabetes, meaning that you should prepare to screen for more things because you are ensuring that this person is not just an HIV person or is a TB person, but can we check what else he might benefit from us? Meaning we are going to incur more costs around variable costs, things to do with service episodes, things to do with tests, and for platforms, if you had the 30 seats in the clinic, you may need to expand them to 100, which means you may also need to expand space. If you want to expand coverage, quality, you're going to incur more costs because those will go with costs. So the point I think on that slide was, yes, cost savings, but there are costs which needs investment, and we need to put some money on this journey. Otherwise, we will not save enough to deal with everything we need to do. The fourth agenda is learning. Now, this learning is one of the reasons we are phrasing it into 3 phases. We need to ensure that we correct ourselves as we go, because we are not going to have it all correct at the beginning. Also, we are going to have what we call fast adopters, or people who have come up with models that work better. We should be able to go and learn from them and improve ourselves. In other words, if it's a facility level, there could be those that are doing better. If it is around procurement, we could find mechanisms that are working better in one place, and we want them to go to other places. In other words, local action planning versus standardization is key. While doing this work, I've been trying to resist the pressure to make a standard where everybody integrates the same way across the entire system. And this is why. We think that every facility, every entity, when they sit down as a local team, they will figure out, this is the framework we are given with those elements. Where are we in finance? Where are we on patients getting comprehensive care? Where are we on workforce? In there, they will find areas to integrate faster than we can prescribe at this level. We think that that approach of allowing entities to actually look at their system using that tool will deliver better, because they are able to identify low-hanging fruits, they are able to plan for them, and they are able now to report. And once they report, I believe we shall figure out that, oh, Kasese is doing wonderful on the issue of human resources. Can we take these guys struggling on how to deal with their workforce to go to Kasese and see how it's done? And in there is what I'm calling learning. And we believe that learning goes with adaptation and a support. And we've created a tool to support this learning, which is being benchmarked on the joint evaluation framework that is provided by the JEE, which is the Global Health Security Agenda, where countries sit as countries to evaluate themselves and later invite externals to come, but after they have done their own in-house evaluation. We believe that that is the model we need also here. And when you use that approach, you have a way to kind of create your own pathway up to the top, where everything is integrated as the 3 ones. But your pathway may not be the same as another, depending on where your starting point. But also you can assess and see where you are in red, where you are in green, and see how to lift those areas. So there is a situation analysis which was done and is available, and these tools have been also pilot tested in about 67 facilities, and you'll be able at least to use those metrics to guide you, and of course the district can use that also to assess and support their facility. Regional hospitals can do the same, and national level can do the same. The risks, and I'm about to finish, the risk on this journey that we thought we would speak about is that projects and projectization, now people are already thinking, how can I write a project on integration and find a funder? Now, that's the wrong way to think about, but this, we can't stop this, but we would like to let you know that it's not the way we would like us to think. We would like to think of how do we lift the system around integration, and whatever resources that come, we don't want to just have a project on one element and leave out all the other elements, or do it in one place and not the other. We also think that there is slow adjustments, especially at those entities that work at a higher level, district, region, and the central government. And central government here, I'm not talking about Ministry of Health. There is finance, there is commissions for health workers, and there are many others that we depend on, which also need to support us. The mentor model I've talked about, the cost-saving model. While doing this, everyone was like, hey, we are going to do cost saving. It was literally in every interview. And I was scared whether the savings will be enough to take us all the way. We can't succeed without the global health initiatives also helping us, because Global Fund, I don't know, PEPFAR, all these agencies that are out there that help us to give us funds, they give us prescriptions of how we should do right, how we should manage. Those prescriptions, many of them keep it into a vertical project. We think that we also need to negotiate with them to see how we can relax on those stringencies so that this process can succeed. Leadership is important, but it's not only leadership from the sector. We want leadership at every level. If you're a manager of a health center 2 or 3, we need leadership there. If you're a manager of a blood transfusion, we need leadership there. That is showing integration. Chair, I'm about to finish. The rest, I think, the issue of the pendulum we need to manage. We need to ensure that this time we stay the course, and that's why I think I've been asked to be here. To sum it all, integration is fundamental to our success, and particularly to dealing with the risks that we are facing right now, but also ensuring that we drive this sector in a way that coherent. We've had a lot of missed opportunities. I was here when we used to have only small grant. In 2003, when all these funds started to flow, I was also here. I'm still here, and thank God. But I can tell you that the vision we had in 20,000 of having our budget then doubled and what we could do, I can say that the monies have been multiplied probably 100 times since that vision. But what we could do has not been multiplied as much. And I think that is the missed opportunity. Yes, there are areas we've made, and the minister yesterday talked about them, but we should have been doing much better with what we received since then. And I think there, is what we would like to make sure you guys, particularly the young ones here, they manage the little coming in the next decade and make it go further. Fragmentation is what we need to minimize. We've had history of integration in this country. This is not new. I know that there are incentives and some of our colleagues may be on the losing side of this job in terms of work and stuff. I think sometimes, I don't know, we are taught to teach patriotism and to learn patriotism. I don't know whether it's enough to say, please take the pain as we find the alternatives, but we need to make this journey continue. Yes, if we are able to get any additional help, it will be unfortunate if we went back to our ways. And the goal, as I finish, is still the commitment to build a resilient, affordable, people-centered health system capable of delivering continuous integrated care across the life course. And I want to thank you for your good listening. Thank you.
Thank you very much, Professor Freddie. He's taken us through a summary of Uganda's integration framework. He highlighted a number of principles that informed its development. I'll just quickly list 4 of those: people-centeredness, PHC being the foundation, and then, of course, distributed leadership. Here, each and every one of us is called upon to do their bit. It's not really anyone's, it's not just one person's role. It's not the PS's role. It's not the minister's role. It's not Dr. Stavia's role. It's all of our roles, and we all have a collective responsibility to make it work. And then, of course, ensuring that the communities continue to inform the way that we think about integration. He also talked about the 3 phases of integration. He talked about the stabilization phase, the consolidation phase, and the transformation phase. So with that, we'll head into our panel session. I know we might have some questions for Professor Freddie, but let's keep all the questions and we'll go through all the questions together, questions for the presentation and for the panel presenters. So we'll go with our panel questions now, and I'm going to start with Dr. Kudelia. Dr. Kudelia, you have been supporting the coordination of the task force, which has supported the development of some of the guidelines that have operationalized integration. And so with this, I would like you to share your experience in leading us in that process, and really with your experience as someone who is part of MOH that's been leading and driving the implementation of this policy shift. And then as you conclude, also just briefly take us through the priority areas as we move into the consolidation phase of integration. Dr. Kudelia, over to you.
Okay, thank you very much, moderator, and I would like to thank the CHAI team, the Clinton Health Access Initiative, for inviting us to this panel discussion so we can share the experiences of the country. A lot has been going on during the last 3-4 days of the conference, and I think integration has been integral in most of the discussions. So straight to the question, the experiences. First, I would want to thank Professor, who has taken us through this presentation, and really for the audience that is listening, if all of us followed each of those slides, I would want to quickly say in terms of our first experience is that as a country, we are literally following almost word for word within that framework, which I think is a big plus for the country, that we have a guiding document that has been able to quickly guide the country in what direction we need to take. But that aside, I want to mention some of the practical experiences that we've gone through, really at the level of the ministry, and I want to liken it to a situation where probably we were thrown into a swimming pool, and everyone had to find a way of how to keep afloat. So I want to say that nobody has drowned, the country has not drowned, and we are swimming. Some people are about to get ashore, some people are still at the tail end, and as a country, but that is the general experience. So this was marked by a lot of, I'll call it shock, initial shock that came in. But immediately we had the experience of how the leadership and our governance came in for decision making. And so at this point, the fact that the country was able to quickly come up with guidance to guide the country in terms of the circular that we saw having the framework being developed, and quickly developing practical guidelines that would be supporting the frontline health provider to understand what this whole integration and putting the patient at the center actually meant. So for us, that experience as a country that came on very quickly and being able to adapt from our leadership, and from the leadership up to all the lower levels in terms of leadership, the regions, the districts, and the health facilities, including the communities, was really a plus for us. And because of that, we were able to take action. We've seen what the framework looks like, but I want to make it more practical. So within that framework, some of the experiences we've had is we quickly got on ground to ensure that we had continuity of services continue to happen through our service delivery task team. We had an HR task team that was also set up with the purpose of ensuring that the workforce is being looked at. And I think all of you have seen through the integration framework that the workforce is going to be a very big one, including capacity development. So having that quickly developed, developing practical tools, training materials, and reaching over 1,900 health facilities in just a space of about 7 months, I think really was commendable for the ministry to ensure that the frontline health worker knows what they are going to do. And of course, mention was made around the financing. Quickly, our leadership rose to the occasion to ensure that at least what was lost from the stop order and the work stop order, we were able to get onto a cabinet memo discussion, and I think you've had the discussions around the supplementary budget. So we see that those raw experiences, and of course, we were met with challenges. I think the other experience is what are those challenges that still we face, but also continue to go on. The bigger ones really are around our information systems, the issues around staffing, and but I want to say that, Chair, what we have observed as the biggest experience has been the building of resilience from every stakeholder. And as someone mentioned, this was not about the ministry. This was around everybody, right from the community, right from the in charge, right from the district health officer, to the regional referral hospital senior executive consultant, being able to be resilient, absorb the shock, and get on. So we're at the stage where we're now on the action, moving on. And as we've seen from the integration framework, step by step, all the pillars that have been mentioned in the framework have now been actualized, and we are moving through the processes of stabilizing, which is to ensure that we have continuity of services, putting everything together, the lab, the information systems, access to services, the finances. And our vision, as you asked, Chair, is as we get into the consolidation phase, we are not sure how long the stabilization will phase. As you heard from Prof, some people are fast adopters, others are slow. But we know that to consolidate, we are going to have to look at how we align the programs, how we look at our data systems, the health workforce, but most important, the client satisfaction with all these changes that are happening, and those are going to be our priorities. Thank you.
Thank you very much, Dr. Kudelia. I love that you've also really emphasized the point around client satisfaction, because it doesn't matter what we all do if at the end of the day the recipients of care are not happy with the services. So that will continue to certainly be a center of how MOH plans these services, and I'm glad you've emphasized that again. So I'll move on to Dr. Batibwe. Doctor, you're the executive consultant of Mubende Regional Referral Hospital and, of course, overseeing the regions served by that hospital. So would like you to share with us what the progress has been within your region, the different hospitals and facilities within the region, and really also share with us what your current efforts are around functionalizing the regional support mechanisms for coordinating integrated services within that region. Over to you.
Thank you very much, Coordinator. In the region of Mubende, where there are 5 districts, we've had
Recording in progress.
We've had some progress, significant towards the integration, and we had the national trainers of trainers training way back in May 2025, and we got 4 trainers from John, and these ones came back and trained others in May 2025. And a total of 40 district trainers were generated for integration. And this is a good number. And as a result of this, 6 districts conducted TOTs, and each district also trained 5 trainers, and overall we got 150 district trainers. So we got first aid training occurring in a number of facilities around July 2025, and there were a number of facilities targeted and trained, and these ones have all adopted the chronic care model. We've had the trainings in Mitiana, in Mubende, in Kangalo, in Chankwanzi and the Kasanda districts. And overall, all these have been supported as IRT sites, and including those which are even church-based, the private not-for-profit organizations which we had in that place. We had active participation of leadership, including the leaders of facilities, the district local government, and we also want to report that most staff were positive about training. There was active participatory learning, coupled with scenarios that help teams to conceptualize what all this integration is all about. So overall in Michana, there were 18 facilities which were trained, and with 83 participants. Kasanda had 13 with 52 participants. Uganda had 13 with 55 participants. And all this continued also in other facilities. This is how far the training has occurred so far in these districts. But also a number of meetings have been held to continuously monitor and mentor them in this aspect of care, where the integration is key. And we're looking at the GOE staff being trained in the HIV management, as well as the COAG or partner supported staff being trained in the reminded actually in the routine management of care for these patients. So that's how far we have gone in terms of training in the region. And overall, I think there's been some experience of satisfaction that now this care point for chronic care is active in most of these areas. There are still challenges of stigma a bit among us, the clients. Some still feel uncomfortable, but we still believe it will be time, it will take time for them to appreciate this is the way to go. Everyone who goes to the clinic has his business is sick, and they should also mind their business and not worry about other thinking about them as maybe being different patients. This one thing we can't avoid. But also the health workers on the other part have also been integrated in a number of aspects, like in outreaches, in generalized meetings, and in performance reviews. And in so doing, we've been able at least to get integration cascaded out into all the facilities in the region. On the other point where we are concerned, how can the regional support supervision mechanism be functionalized to coordinate integrated care systems for improved patient outcomes? Already the Minister of Health had designed a regional referral hospital strengthening approach, the mechanism as normally it's referred to, while the ministry remains at the helm as policy, strategy, resource mobilizers, setting standards, and capacity builders, and well monitoring and evaluation. And the region, we became the governors and the leaders in service delivery and implementation of government policies. Here we are coordinating public health departments and also offering specialized services, as well as also carrying out supply chain, and performance evaluation. The districts remained with the function of carrying out the evidence-based programming, actualizing information management systems, and also ensuring that there's a functional service delivered at all these points in the facility in the district. And also, they will also monitor the community and supervise and mentor them. So we have to look at a way how we bring in the integrated care system. There are two ways of looking at it. One of them, if we're talking about integrated care systems, which Professor alluded to as person-centered. This one leads to coalescing different clinics into one, the chronic care clinics, for example. It brings us to an example where, like in our case, we had the Ebola survivors also brought on board, and they had to deliver in the same facilities with special precautions. I've also had pharmaceuticals, clinics, and preventive services also integrated and into similar plans and schedules. And the Ebola one gave me a very interesting experience because we had a breakout out of Ebola in Mubende. And it taught me how daunting it is to manage the dynamics of managing a health workforce, which is allegiant to different donors and agencies, as well as the government of Uganda. It was really a very big experience for me. It was a nice one that actually I realized they also need to always integrate healthcare for epidemics in the future. So this is one thing to also look at. But now, how can this mechanism be harnessed further? It is mainly, from my experience of finding Movendo, we have looked at the participatory planning with the districts and budgeting. So we have one work plan which is agreeable at the district level, but then it is also integrated into one of the region. And this one brings us to the point which we've been talking about of actually trying to integrate budgets and work plans into one, right from the top. I'm still waiting to hear us commit ourselves as discussants and participants and the members of the Ministry of Health that in the future we shall be having one budget which has the donors and the GOU on the same face sheet. Actually, if you looked at the templates given by Minister of Finance and the Planning and Economic Development, it has an aspect of donors, external financing on it. But for some reason, it is left 0, 0, 0, 0, 0, which is not true. So I think if we're really getting integrated, let us be honest and get the budgets on board. And they're reflected there how much is coming and by who wants to go and do. The second one, which I think is very key for us and which we've been trying to do in our region, is to get the commitment of the leaders. Let leaders commit. I'm talking about the COW, being the accounting officer of the district. I'm talking about the DHO, being the technical advisor, the technical chief in health services delivery in the district. Let them commit themselves in writing, preferably like we did in Muvende, how much they can improve within the available means, within the available resources they have in terms of patient outcomes. We are working towards this, and I think we moved a good step so far. We've committed ourselves. And then we are now having the biostatisticians and other information technologists we have to give monthly updates on the progress towards those targets, whether you've looked for it or it is there. And we have also expanded on the extent to which the biostats collect information. It's beyond DHIS too. They are going into the departments, they are going into the record books, they are going to theater books, they are going to the outreach reports to be able to report, to generate data and analyze it to see if we are really moving in the right direction. So when we have this in place, this is also coupled with, of course, the key performance indicators which have been coming all along through. And with clear targets, I think we shall be able to make serious progress. In this way, I believe that we shall talk about improvements in patient outcomes. And you are talking about a massive one, reduction of institutional mortality, for example. Timeliness of response, or effective response to epidemics in our setup. Days of availability of medicine and supplies in facilities across the board in the region. Levels of client satisfaction. We have to see them improving and quickly respond whatever it is that is causing. I think in this way, the regional support mechanism can improve patient outcomes. Thank you very much.
Thank you very much. Dr. Batiwe. I'm hoping that the hand claps for the next speakers will be louder than that, but thank you. Thank you. Yes, I think he's really highlighted a number of things, but maybe just to summarize that every institution will probably rise and fall with the strength of its leaders. And we have seen what good leadership can do. He's highlighted the importance of us committing to some targets at every leadership level. He's highlighted how Mubende region has been able to do that, committing to some targets in terms of patient outcomes, in terms of patient satisfaction. And I think that's a key part of how people really monitor their performance. The other thing that he's really touched on is the issue of the joint financing mechanisms. Very key. Again, at every level, I know the Ministry of Health is still strengthening accountability in this area, ensuring that all the finances that are coming in at the national level are jointly managed. But I'm glad that we also see that the leaders at the regional level see the necessity of this and are ready to start to implement it. So I'll then move on to the next panel presenter. Please keep your questions. And that's Dr. Rita Makabai. So Dr. Rita, as one of the people supporting Baylor Foundation in delivering health services to the recipients of care, please do share with us some of your experiences, especially in the changes that we've had to all endure in the way that services are delivered in the course of this year. So please do share with us your experiences in terms of that, as well as the achievements you've seen in supporting facilities to integrate HIV services into routine health care.
Thank you very much, Dr. Veni, and really to thank the previous speakers. I think they've laid a very good platform onto which I can then build. I bring greetings from the Executive Director of Baylor Foundation Uganda, Dr. Dithan Chiraga, and the different teams within the regions who have made some of the achievements we've been able to get a possibility. I would like to start by raising or really reiterating one of the comments submitted during the keynote address yesterday by Dr. Queen Dube. She mentioned that limited workforce capacity remains one of the barriers to achieving unified and integrated action. So, and as a capacity building advisor at Baylor, that is really the focus of my work, that we build teams that are competent to be able to deliver the integrated services as guided by the Ministry of Health. So I'd really like to acknowledge and thank the Ministry of Health for the strategic direction. As Dr. Cordelia mentioned, we have all the tools, we have all the standards, and I was one of those who benefited, Dr. Batiwe, from the regional training that was conducted in Mubende Regional Referral Hospital. So that really further emphasizes that without collaboration, one other key thing that was mentioned during the keynote address, that collaboration saves lives. So, and I've seen collaboration during the integration agenda. It would not be possible by any one entity, right from the Ministry of Health, the respective regional referral hospitals, the district health office, and then at the health facilities, engaging with the IPs and with the support from our development partners. So there's been a lot of collaboration to achieve what we've been able to achieve in this short time. And thank you, Chai, for convening us to be able to share our experiences. So what we've been able to participate in as Baylor Foundation Uganda, still engaging with the Ministry of Health and being part of the technical working groups. I think that is a plus and really adds on to the collaboration effort without collaboration, we shall not achieve much. So thank you for that collaboration. And thereafter, the different cascades of trainings have been talked about. And as BFU, we then engaging with the regional referrals, as well as the DHT, the DHO's office. We coordinated and supported the training of the district TOTs. And for the BFU supported regions, we're able to train about 1,032 district TOTs. That's for Poto Mubende Hoima, in Mbale, and then the Karamoja region. Subsequently, we've been able to cascade these, working collaboratively with the key partners, as I've mentioned, and for the FPM region, for those facilities that were targeted for training, they have been trained. For the Hoima region, I know I think by the end of last month, we had achieved about, we're at 30%. But as I speak now, over the past 2 weeks, trainings have been happening. And so far 90 out of the 122 facilities within the Hoima, within the Bunyoro sub-region have been trained. Due to some logistical delays, but I know processes are in place, we are planning also to train the Karamoja region, because we had about 20 facilities that have been trained so far out of the targeted 52. And similarly for Mbale, Mbale is also planned for as resources become available. But what's happening now is we are continuing to finalize the trainings within the Bunyoro sub-region. And then hopefully next week, Karamoja will also start. So as I mentioned, having trained with the skills to do it, but also there is need, as we engage with the teams, to have a mindset shift. There's a statement that I came across, and I think it's relevant even as we change our mindsets, and the integration agenda has come, and we cannot continue to do things as previously. And I will borrow a statement from one philosopher who said, the greatest danger in times of turbulence, like the ones we went through, is not the turbulence itself. It is to act in yesterday's logic. So I think that is what we've been able to achieve. We are supporting integrated mentorships, implementing integrated community service models within our supported regions. We have a digital audit tool, and then some QI projects that have started. So you realize that the things what we are doing are trying to operationalize the different 11 standards that we have. We are still in the phase of consolidation, yes, but we hope we shall shift, in stabilization, but I hope we shall shift and eventually reach the third phase of transformation. It is a journey, it's a learning journey, as Professor had highlighted. It will not be achieved in a day, but I think we're on a good course to achieve those. So what are some of the priority areas that we are working towards, and that other IPs can also do? I think the priorities have already been mentioned by Dr. Cordelia, and for me it's about understanding the standards well enough to support our health workers to translate them into tangible results that we want to see at the end of the day. At the end of every training, work plans have been, integration work plans have been developed. And I look forward to a time when we shall have the post-training follow-ups and mentorships. I know all the different facilities have either adopted the chronic care models or the OPD care models, and that they're at variable levels of integration. And we have the tools that have been provided for us. So as we move forward into once we complete the trainings of our sites and move into the post-training follow-ups and mentorships, that's what we shall be assessing. I know the ministry did some technical support supervision for selected sites, but we need to reach to each and every health facility that we have. And really to reiterate that collaboration indeed saves lives, and our priorities need to be guided by the frequently asked questions that come from the people on the grassroots. And as we engage in the different platforms that we are, things about the EMR, the data systems, and not being integrated is something that is top on the agenda. And I know efforts are in place to have those harmonized. Aspects regarding community integration continue to come up. Issues of stigma. How do we work better as implementing partners to contribute towards stigma reduction? Then also aspects of patient tracking and retention, and of course, infrastructure and space continue also to come up. So listening to the people who are doing the actual implementation is a qualitative way of using data to inform our next steps. So for me, I think if we continue the platforms that we have, listening and having our HR optimized, during the technical assistance transition approach that Bela is moving into away from program implementation, we are now focusing on really listing afresh the different mentors that we have across our supported regions, listing the different skills that they have in an effort to move towards having a multi-skilled mentor who will be able to offer an integrated service or a mentorship when they go to the different health facilities. I think the human resources are the best resource that we have, and we need to empower them to be able to achieve what we want to realize. So thank you. That is it from me. Yeah.
Thank you very much, Dr. Rita, and I think you've implored us to ensure that as people who provide technical assistance to the frontline health workers, we need to make sure that we have understood the standards and are able to then pass them on to the frontline health workers. So I hope that all of us will take that home as we leave this room. We are going on to our last panelist here, that's Amy. So Amy, you're representing the UK government on this panel, but also other development partners for the government of Uganda. So would like you to share with us some of the emerging resource mobilization opportunities that Uganda can tap into in order to finance some of the health priorities that have been highlighted by the panelists here, and also the other priorities out there amidst these donor funding cuts. And then as you close, please also comment on the current priorities, funding priorities for the UK government and other implementing partners in regards to implementation of integrated services. Over to you.
Great, thank you. And huge thanks to Prof. Freddie and to the previous panelists. And I'm also very aware that I'm the last speaker before I let you go home and see your families and have dinner. So I thank you very much for your attention for the next few minutes. So we're all very aware around the decrease in external assistance, and that has accelerated in the last few months, but it was on a downward trend, as Prof talked about previously. And I think we need to accept that this is the new normal and we need to adapt. And I think Uganda is a fantastic case study of how you are doing that. So this disruption offers a real opportunity to do things differently that we need to grasp to improve accountability and impact of precious resources and reduce that dependency on external funding streams. And we also know, I think this conference is really demonstrating that alongside that seismic shift in external funding landscape, we're seeing this increasing double burden of disease and increasing comorbidities. And that in itself is a driver for more efficient use of scarce resources, a focus on prevention, on primary healthcare, which we know is better value for money, and for increased integration around the patient rather than the disease. So none of this will be new to you, but I see two main opportunities for Uganda's health sector around resource mobilization. And the first is improving use of existing scarce resources, more health for the money. And the second is domestic resource mobilization, or resource mobilization more broadly, and that's more money for health. And so I really didn't want to jump straight to resource mobilization because I think there is a real piece around better use and better value for money and efficiency of existing resources at all levels. And there are a number of ways to do this. There's better harmonisation, alignment, transparency of both on and off budget funds behind the national plan. For instance, the visibility that the virtual pool that the Ministry of Health and WHO and others are working to develop for off-budget finances and supported by UK technical assistance. I'm really interested in a marginal aid approach to promote sustainable transition and government in the lead. Often donors are renowned for cherry picking good value for money activities and leaving governments to pick up the tricky stuff. And instead, I think this is the real benefit, and I think Uganda is really leading the way in much of this around really clear visionary national plans for the most cost-effective integrated packages of interventions that domestic financing can come in to support, and then global health initiatives, bilateral donors, other multilaterals can come in around the edges to support the gaps rather than those core pieces. And that in itself increases the stability and the longer term likelihood of those core services remaining. There's a piece around improved public financial management and a roadmap for improvements at all levels that improves planning, budgeting, spending, accountability, and gives all partners confidence in using government systems at whatever level. There's prioritisation of spend, and not just spend, but other resources, time, staff, to achieve impact. So working smarter with the same or with less resources. And that could include health technology assessments, the proportion going to primary healthcare and prevention rather than tertiary, some digitisation, more funds to frontline compared with administrative costs, pre-service rather than in-service training. You know, I know you know all of this, but I think it's worth saying that these are some really important things to do to think about how can we get better efficiency out of existing resources. And then integration, I think, is a tenet of this as well. Well-integrated systems beyond the co-delivery of multiple activities, but properly integrated systems can improve cost effectiveness. But as other panelists have talked about, they can also incur additional costs, at least initially, when thinking about planning and alignment. So that's about more health for the money. And then there's the more money for health piece. And, you know, Uganda, again, has done a lot of thinking about this over the last few months with the May National Dialogue. And I won't go into huge amounts of detail because I think a lot of you already know this, but lots of things that Uganda is already exploring around increasing the percentage of GDP that goes to health, the whole Abuja target, recognising health as an economic driver for broader development, considering national health insurance, pooling finances, spreading risk. But it is worth saying that that's not a quick win, and often places where it works best, actually government subsidises that. So it's not a replacement for domestic resources, it's a way of channeling and pooling domestic resources with other resources and spreading risk. Sin taxes on sugar, tobacco, alcohol, or allocations from road users towards injuries. Again, not straightforward necessarily, and there's discussions about earmarking and whether it goes into a general pot or health-specific pots. There's then the broader conversations around boosting local manufacturing and other innovative financing, debt restructuring, climate finance, and those kind of things. But I also wanted to talk, the second part of your question was around the current funding priorities for the UK government around implementation of integrated health services. And again, I really want to commend Uganda for the forward-thinking work that you've done on integration, for the robust framework that's been developed, the ambitious leadership that the ministry has shown. I think you're really ahead of the game in this, which I think it gives a really great platform for future work. So 3 relatively quick things that I think are priorities, and I'm coming at this from a global health initiatives, multilateral lens particularly. I think there is more work to do to align the global health initiatives, Gavi Global Fund, behind the integration agenda. I think there's a second piece about ensuring we leave no one behind, and a number of other panelists have talked about this as well, about stigma and other things like that. And then there's this piece around learning, which I think is really important as well. So firstly, on making the global health initiatives work better for countries, I think the global health, there's a real opportunity now with Gavi 6.0, with GC8, the Global Fund Round 8, to think differently about how we approach those and to really make sure that the Global Health Initiative funding is supporting the integration agenda at all levels, not only at service delivery level, but and integrating HIV, TB, malaria within the public health primary healthcare platform. But I think, as Prof talked about as well, at different levels, integrated program management across the disease programs and the health system functions to reduce fragmentation, enhance coordination, shared accountability, integrated monitoring and evaluation systems for data collection, reporting, analysis, use, tracking outcomes, ensuring quality, supporting evidence-informed decision-making and including those key vulnerable populations and community voices, integrated financial management, as my other colleague here talked about, planning, budgeting, resource allocation across programs. And I think otherwise we risk missing some of these system-wide, sustainable, effective integration approaches that strengthen the primary healthcare platform and the broader health system. So some thoughts, and Dr. Stavia and I talked a little bit about this over lunch, but could the GC8 process sit under the National Advisory Committee on Integration or another body within the ministry? How to get that integration expertise into the process for developing the GC8 application? Could we have a single funding request with global funds driving the government of Uganda's integration agenda? And I think we really need a different approach from previously, and we can grasp that opportunity now, but we need to start with the groundwork now. Second point around equity, other panelists have talked about this as well, but I think just really making sure we have a continued focus within the integration agenda on the needs of marginalised or criminalised groups whose needs are unlikely to be met by integrated services delivered through government health facilities. They might be, but I think we really need to look at what the evidence is showing us. And so how to balance the majority of services which can be delivered by primary healthcare versus those which might need a more targeted approach to meet specialist needs, maintaining quality, leaving no one behind. And then lastly, underpinning it all, I'm really keen that we seek out opportunities for learning what works. And Prof. Freddie has already talked about this a little bit, and this is why I'm so pleased about this underpinning integration learning agenda and the integration maturity framework, and really being able to track Uganda's journey towards integration. And I think there's lesson learning within Uganda, for instance, how to build global fund-supported community-led monitoring, international systems broader than the 3 diseases, hearing patient voices to strengthen and improve services at the local and national level. But I also think there's external peer learning partnerships across the region, across the continent and further afield. I think Uganda has a real opportunity to share the way that it's developed its integration agenda with others. And, I think we should document and share and shout about these lessons. Equally, I think there's lessons to learn from other places. I've just most recently been working in Malawi, and we did quite a bit of work looking at health technology assessment and how to bring that kind of approach into resource prioritization and decision making. And I don't know what the situation is in Uganda, but I think there's a lot of regional learning that could be done. So I'll stop there and hand back to the chair, but thank you very much for the opportunity to speak on this panel.
Thank you very much, Amy. You've highlighted a number of opportunities for increasing the health we get out of the money that we receive, and I think you really emphasized the need for us to think through our GC8 planning processes and ensure that they are aligned to the priorities that have been stated on this panel and in the earlier discussions that we had. And then, of course, the challenge we have for more resource mobilization. It's probably time for us to think about the AIDS Trust Fund. I know there are a number of people from Ministry of Health. Maybe they can help us resurrect that discussion and see to it that it gets implemented. So with that, I'm going to open up this for any comments or questions. I hope we can really keep them brief because we are really time bad. So we'll keep it to a maximum of 6 questions. We have some questions here. Dr. Luze, you can start since you have a mic already.
Thank you very much. Mine goes to Professor Sengoba. It was a good presentation. One thing I want to refer to the three phases that you mentioned, and my question is: are there things that we can And in your experience, what is the time frame, for instance, moving from one phase into another? Because listening to the presentations across the floor, I got the impression that we already in all the three phases, and I don't know what your comment is on that. Thank you.
Thank you. So just over here and then Dr. Raymond. Please introduce yourself.
Thank you so much. My name is Coleman Tayoga. I work with MRC Masaka Station. My question goes to the director of Mubende Hospital. So I wanted to ask, do we need to involve or engage the community as we integrate? In case the answer is yes, at what level do we bring them on board? Because I've had trainings, but I've not heard about the sensitization of the community. Yet the community, they are the consumers of this product integration. Thank you so much.
Okay, thank you, Dr. Raymond.
Thank you very much. I don't know, maybe Prof can help me or Emmanuel, even Makabwa. The biggest challenge we have now, we have trained, we have built capacity, health workers, community health extension workers. The problem is we don't know who and where they are. You can train 4 times, 5 times, 6 times. How do we develop, when and how can we develop a database such that we can, after we have built the capacity the first time, even when it is in medical school or even after medical school or nursing school, how can we build that capacity so that we just build on the capacity, the knowledge they have, and if there are any new guidelines, we just put up that, so that that training database that we can pick up from and keep, I mean, when they transfer them from Mubende to Fort Portal, we know that actually they still have this skill, and we are mentoring, then again building capacity afresh, because it's becoming more expensive and it's becoming difficult for the donors to continue funding this area.
Thanks, Dr. Raymond. I think Dr. Kodelia engages a lot with the HR department, so I believe we should be able to speak to some of our plans around that. I can't see at the back, but I know there are about 2 questions.
Thank you. I'm Elizabeth Ekirapa. I work with Makerere University School of Public Health. I have two questions. The first one is to Rita and Ami, and I'm asking about how can development partners work with probably the human resource division to ensure that we can have comprehensive, coordinated training of health workers happening across the country, because what we've been seeing is, patchy trainings by different, development partners and also by government. As we talk about integration, how do you think we can unify and coordinate this so that we are focusing on the areas that we have prioritized and doing that together? The second question is about human resource. I like what we are doing with the community health extension workers and efforts that are going in that direction. But when I think about the people in my village, they don't just need a health extension worker. They need a community extension worker who will talk about family planning and talk about the importance of keeping that girl child in school and talk about sanitation and talk about all these things. So as we talk about integration and using a multisectoral perspective, is that phase 4 in our integration, or is it part of phase 3?
Thank you. Just one more question at the back, And then we'll have, okay, we'll have two here.
Thank you very much. I'm Dr. Rosemary Molo. I support management of drug-resistant TB in Uganda. My question is about integration of TB as chronic care, but with real-time infection control need, as opposed to, not as opposed to, we have seen elaborated HIV integration. It's also infectious disease, but you might not get it from me when I sit next to you. So the first question is to Professor Freddy. We would love to see real modeling of the TB integration, just as you expressed MCH and other areas into the integration things. Then the second one is to Dr. Emmanuel. How has what is like the success story of integrating TB care into your chronic care services, especially at general hospitals that do not have, probably regional hospitals have had TB units and TB wards. General hospitals are a real concern, and maybe health center for, especially in the OPD area. What are those steps you are taking to ensure that even if we put people together, we are still mindful of the possibility of infection across board? Thank you very much.
Thank you. Just two more questions. At the back, there's a question. Okay. Yeah.
Yes. Good evening or something, everyone. Yes, my name is Nicholas. I work with IDI. So my question also goes to Prof. He gave us an example of the health center for aspect doing surgeries, which took about 12 years. So you've developed a strategic plan. Just mentioned when we are integrating, there's a level of integration already. So how long do you think that the full integration, as for your strategic plan, will be taking place with full human resource recruitment, help merging everything for financing and everything? What is the duration do you expect to take for this to be what action? Thank you.
Thank you. Just over here.
Thank you very much. My name is University Joint AIDS Program. My question goes to Dr. Cordelia. And is there a clear plan to integrate the many number of staff that have been laid off? Thank you.
Okay, thank you. Then the very last question here. The rest of our questions we can use the panels.
Thank you so much, moderator. My name is John Bosco Ntambara, and I'm a student at School of Public Health, Makerere University. So I appreciate so much, Prof, for your appreciation of the complexity and the hesitance to standardize, looking at how the system evolves and how the context differs. I want to pose the question either to you or to Dr. Emmanuel on so far the health center where you have been able to pilot some of the lessons that you've learned, especially when it comes to integration and then the stigma, especially associated with HIV. From the background, there's a program we have been implementing in Semto Health Center 4 in Nakaseke, where the patients are having community insurance, they're kind of supporting them with hypertension medicines. So that with that program, with the integration of HIV services, realize that we have been having these monthly NCDs, but like subscribing for a prescription, but with the integration and services being happening every day, so it is harder for them to be able actually to continue their monthly subscription and monthly refills within the integration where patients and clinicians are supposed to be coming, doing that very clinic every day and keeping up with the schedule. Very appreciation of the complexity and the context really answers the discussions that we've been having at the facility. Thank you so much.
Okay, thank you very much. We'll have the panel answer the questions. We'll start with Prof, then Dr. Emmanuel and Cordelia, then we'll have Amy and Dr. Rita make just a few parting remarks. I understand the one to address to them. Over to you, Prof.
Thank you, moderator, and thank you, audience, for the interest. And I can see the questions also speak the interest in the discussion. Yes, so I'll start with the question about time frame. I think two of you have raised this issue, Dr. Luze and colleague behind there. So the reason we framed it into three phases is that the stabilization phase would take probably the least amount of time, partly because this is where you are trying to make sure that the shocks on the system do not, for example, create service disruptions that people can't get the service. And from what you've heard, even the testimony from my colleague from Movende, and I believe many others across the conference, is that a lot has been done in terms of getting people at least to stabilize. I think I like Dr. Cordelia's presentation. He said they were thrown into the pool and looks like they managed to swim and no one has drowned and some are getting across. So I think in a way is that using that analogy, there are actually some that are actually still swimming, some are getting closer to the other side. So, but that is the phase we would like to see. If this is the phase about getting everybody out of the water, have they gotten out of the water? Are the patients able to get the service? Are they able to trust? Can we give them assurance that the service is here and is stable? And that phase we thought will take a year or a year and a half, mostly two. But that is the assumption of a consultant. I think real life, that answer might come more from my colleagues who have been running the service. But that is but the consolidation phase is where I thought that at least 3-4 years, because you want now there is electronic medical information system you want to roll out. There is the health workers you have to train so that they become as good as the experts that were in the HIV clinics. There are procurement systems that we need to fix. Now, those are going to take a bit of time. And those ones who may need as for us, because they were already not really up to the level. They were still operating at a level that is underfunded or otherwise. So we want to ensure, we don't want to put everything on the bus of integration and break the bus. Some of you are used to the bus. But the point here is that you want at least that time to start now consolidating those aspects. If we find that medicines are key and they're not coming, so laboratory testing and laboratory equipment need maintenance, how do we put them on a system? Are we going to buy a system of service like maintenance as a service? Yesterday we were talking about oxygen as a service. In other words, that process might now take us into, because we will understand more what are our constraints as opposed to, right now the constraints are clear, but building the system up and consolidating. So that one is where we thought 3-4 years would be, but the last phase really is a phase of continuous improvement. There is no end to it. So in that sense, I don't have a time frame for that, but this is something we want to become a norm within the way we do business. The question about where to start, which facility or center for to work with, if they are struggling with the issue of contribution and stigma. Again, this is a question that me as a consultant standing here, I can't really speak to all the nuances everywhere. So what we thought would be useful is for us to say, look, if you can sit as an entity, that entity could be health center for, it could be the patients who are contributing to this scheme as a saving scheme, and sit and say, how do we deal with this question? Okay, our patients were saving only for, now they have this situation, they are going into a clinic that is multi-service, in other words, chronic care with many. How do we ensure that in this environment we can see either the integration is within the service to be delivered or within the pooling of funds, or if it is the mechanisms of how to pull the money that they were contributing, how do we do? So I would probably not be in a better standing here to tell you this is how it solve that. But we want to bring that to each and every unit to see if they put integration or service or the patients at the center and the issue is contribution, how do they solve it? Eventually using these frameworks and tools Those tools also can be tweaked. They are not like cast in stones. See how to solve that, and eventually other people can come and learn from you. You may not fix it the first time. That's where learning agenda comes in. The health system is very complex, and I'm glad at the school I teach complexity. And one of the issues I say, it is very hard to use a cookie cut and solve the world's problem. Because if there were cookie cuts, everybody would have discovered it. But I think the issue is to be able to learn from your experience locally, engage those that are necessary to solve or to discuss, and find a way forward, and continue at it. It's not like you're going to solve it in one go. I don't know if there were other questions I was asked to speak about, but I think that's it. Yeah, thank you.
Okay, thank you very much, moderator. There were a number of questions. One of them is about how, at what level are we involved in the community, from our colleague from Masaka. And we can begin right at the very beginning, where we are talking about in the wards, in the common things we talk about, health education sessions, for example. And here we begin involving them. We update them about the do's and don'ts about health conditions in the environment where they are and when they are back home, including nutrition, demonstrations, and so forth. But also the other way we involve the communities is through the official communications. We have been having a situation where I learned this actually from schools. They have talking compounds. I wish we could adopt this also in our health facility setting. Other than putting up all these posters about all these drugs covering all the walls, maybe we should have aspects where we have talking compounds. Again, this will deliver messages to them that may be official, as well as also about their welfare and health. There have been scenarios where we have public events. We're talking about open days where the health facilities share with the community what they are doing, which services they offer, and if they are free or not free, and how they refer patients from where they are to the other better and to another level above. We have open discussions like the baraza, which are commonly called, where the community comes out through their leaders and themselves as beneficiaries of service, and they tell you of how good, how bad, or how ugly your services may be, so that maybe you find ways of improving upon them. This is also coupled with radio talk shows. We talk about specific topics, interventions, signs and symptoms, how best they can be managed, and as well as these small pep talks which occur on the radio, small health education stipends, which just talk about something brief. I think at this level, we begin involving them right from that. But larger still, we tend to pull on their ideas into planning. In the client satisfaction, for example, in Muvende, we pick them and give them back to the individual department. I hold the department head responsible for this complaint or compliment for that matter. And we task them to make sure they improve next time round. And this, I think, a very good way of handling it. Now, Dr. Raymond mentioned it all. Let me try to have a go at it. Many are trained, but where are they? I think you're speaking to transfers you can occur within health systems. Transfer right from, you remember this time when we were in medical school, Professor, you may recall. Those people before us, all of them used to leave the country and go outside. So a few of us remained on to begin serving the country. That's also loss of skills. There have been scenarios where we are talking about transfer of skills from one facility to another. People have been trained and they go with their skills. My take on this is the actual problem is this bit of having focal persons. The vertical programs, NGO donor-driven, pick one person. They train him to become their focal person for certain projects, for certain activity within the facility. And that person does not transfer the skills to the rest. What we can do for ourselves as individuals and managers of these institutions to insist that such a person, when he's trained, he must return and train and mentor the whole group. That in case they fall sick, no stalemate. In case they are transferred, no stalemate. In case they die, we still continue running, as you know. Now, when someone dies in an office, they say, well, who is going to take over that office next? If even he's buried, you know that story, which normally happens in our setup. So I think we have to look at that, I think. And we insist whoever is trained mentors the rest. TOTs should be the way to go now. And we make sure they deliver upon the mandate which they've been given. I was asked to share a success story about integrating TB, especially in a hospital setting. Most if it's a general without a specialized ward, like for us, we are lacking regions. And we even have MDR TB wards. I worked in a general hospital for a long time, and I know what you are talking about. One of the difficult diagnoses to integrate is TB, right from the word. But we used to have TB corners, which were better lit, well ventilated, and we also used to make a big special effort of starting these patients on anti-TB, with hope that within 2 weeks they become non-infectious. I hope it still holds up to now. It does. So this is one area which we can just look at how fast a patient is taken on to treatment once they're suspected. And we also have cough monitors in OPDs. These ones, when you're over coughing, they put you a bit aside and begin suspecting you for TB and take your samples early, which is a good thing. So maybe we can work to us, and also the ward corners, but also promote good designs which promote light and ventilation, which may be very good at the facility level. I don't have a specific story, but that's what I have heard in my experience over time, that this is possible. And indeed, of course, these are community programs you have of good nutrition. You've seen people who have stayed with people with TB in the same household. They don't fall sick. We know these stories because they've got better immune system. All those may be taken into consideration. Now, Namara, you mentioned about the stigma. I think it was the point you brought out again, stigma, and then you correlated it with the monetary fields, how they may be affected by integration. Actually, the other chronic care clinics, TB, DM, even sickle cell, they have been carrying out some bit of also refills for such patients, maybe for a shorter period. But one of the best practices they learned from the HIV clinics is that you can actually give them pills for a long period if they are stable, and you teach them how to monitor. The downside mainly are those who are on insulin, for example, and then the DM clinic, or whose hypertension is unstable, and they need to be monitored. But already this, I think, is already occurring. And the whole thing about stigma is one thing which even yesterday I mentioned, we have to address. Stigma may be self-stigma, may be public stigma, may be perceived stigma. I keep asking, who is benefiting from this stigma? Especially the perceived one, when someone feels, well, they're saying this. Well, I agree, you may have certain signs and symptoms which may put in that complex style. But I think through counseling and trying to get this part of this kind of thinking, we can be able to overcome stigma with time. Thank you very much.
Thank you very much, Dr. Emmanuel. Dr. Cordelia?
Okay, I had one question, but I'll request that I probably just give a bit of some guidance. And this is in response to, I think, Dr. Raymond and Professor Elizabeth, yeah, I think around HR. So as Prof mentioned, he's a consultant in this process. And I also mentioned earlier that the job of the ministry is to take this framework and make it practical. I also mentioned that within the practicality, as you saw the domains in this framework, one of the domains that is being made practical is the issue around human resources for health, either through the health workforce, issues around recruitment, absorbing staff, performance management, quality, and all those things related to that. But there's the aspect of institutional capacity development. And this pillar is housed within the ministry with specific departments. So the practical approach is that with this integration that has come on board, which we are looking at as an approach, the questions that we are asking ourselves is what are going to be the stabilization, the consolidation, and the transformation phases within the HR. So to answer you directly, Dr. Raymond, one of the issues around institutional capacity development, this has already been taken up. And so one of the areas is around our information systems for human resource. How do you track capacity development? How do you track who has trained, who has left, who has gone where, what skills have they developed? So within the matrix of HR, those are some of the questions that are actually going to be answered. Now, and also same to Prof, I think around the issue of what support. So because the government really is in charge of mobilizing resources, so when you have a matrix and a roadmap showing where you want to go in terms of human resource, both for capacity and HR other issues, then you're able to mobilize for exactly where you want to go in the space of integration. So those are the phases we are in. Those are the processes that are practically happening. There's already a pillar around HR led by the commissioner. And those are some of the questions that are being answered. And especially even around the health workforce, you talked about the community, the choose. We talked about that we have health inspectors, we have health assistants. So our community department has already defined what package is going to be given and to be delivered in an integrated manner. And they have defined which workforce is actually going to be supporting those packages within the community. So as you heard someone saying, it's not yet 80%, probably not yet 70%, but this is the phase that has started, and we want to move from where we are to get to where we should be going, using the approach around integration as a vehicle. And then Dr. Luze, I think the issue around measurement, maybe we forgot to mention that there are some measurements we are looking at. Like we mentioned, this is a phase of learning, relearning, and unlearning. So some of the questions that have come in is like, how shall we know we are where we need to be? And right now, there's also, like I mentioned, the pillars are active. We have a pillar around just the M&E, for example, the information systems that is beginning to ask these questions. And within that, we've also developed tools to support our supervision, but those tools are based on these domains you've seen in the framework. And we're asking ourselves if people reached at this stage and the maturation matrix that Prof talked about, where we're able to stage a facility. So those are some of the attempts that we are making. And if you saw in his slides, some facilities are in green, some are in red, others are in yellow. Those are some of the different ways we are using. And like we said, learning, relearning, and learning is really what we are going to look at. I also want to emphasize the person that asked about the issue of TB. Integration is not going to replace the principles of care. TB is an infectious disease, and we know that anywhere a patient comes and if they are coughing, the principles around isolation, moving away and still apply even in the face of integration. Thank you.
Thank you very much, Dr. Kodelia. So last, let's have a few parting shots from Amy and then from Dr. Rita in under a minute, please.
Yes, very briefly. I think my question was around how development partners can work with the Human Resource Division to better coordinate training. And I 100% agree. I think as resources reduce, we need to better align and get better value for money out of all the resources that remain in the system. And in a similar way to how we're working with the Ministry of Health, with WHO and others on this virtual pool to look at all off-budget development partner support to give better transparency of resources so that the ministry can then see what resources are available and then really look at how they come under the one plan, the one national plan. I think along a very similar line around one plan, one budget, one M&E, we need to be taking that approach to across the whole health sector and then within the building blocks of the health sector.
Thank you very much. Dr. Rita?
Thank you very much. Maybe just a comment as regards what Raymond mentioned for a training database. The Integrated Human Resource Information System has a module that captures data on each and every health worker that we train. The challenge is on optimizing its use. If it is optimized, we would know which health worker has been trained in what specific area or specialty. So really a call for that system to be made fully functional. There are sites that are as low as 30%, districts that are as low as 30%. Yeah. So
Okay.
that is it from me.
Okay, thank you very much, Dr. Rita, and thank you very much to all the panelists today for sharing your thoughts on integration, and to the audience for your interest in integration, as well as your endurance. I know it's quite late, so thank you very much for staying behind, and let's keep a conversation on integration.
Thank you. Thank you.
Madam Moderator. Thank you. Thank you, Prof. Thank you, Professor.
Thank you very much, members. A big hand clap to the members and Dr. Veni for chairing the session. As they take the group photo, we want to thank each and every one of you for having really kept active and engaged throughout the sessions and for bearing with us. Today we finished 30 minutes late, but I think it is well given that we started on time, and shows the commitment and the amount of subject and the attention that we have given each and every topic. So colleagues, and call you upon for tomorrow's session. We have quite a packed agenda. We request that we keep time, especially for all that are presenting tomorrow, so that we are able to cover everything, given that it is the last day. Once again, thank you for being with us today. Tomorrow will be our last day here. In case of any issue that you feel should be considered as we move, please pass it on to the Secretariat. We are open to receiving them so that we have a concrete action plan. Have a good night and take care of your properties as you move out. Thank you.
in countries to which we completely all sorts of junk food. The risk factors that are represented. These risk factors are quantity. Then and promoting active